Great to see everyone. It's a real pleasure and privilege to be here. I love this meeting. It's small, it's intimate. I think you'll find if you're a first-time attendee or coming back to this meeting after an absence, that everyone is open and welcome to collaboration, to talking. So feel free to approach everyone and anyone at the meeting with questions, and I think it can be a vibrant discussion. So thanks for having me to speak. I'm going to be talking about olfaction, how it relates to cognition in people with HIV. So I'll talk generally about olfaction. I'll talk a little bit about olfaction in the context of Alzheimer's disease, just because it's a good model and has been studied a lot. Then I'll talk about olfaction in people with HIV, and then tie that to olfaction, HIV, and cognition. Throw in a little bit of COVID in there because that's what's kind of brought olfaction to the spotlight lately, and talk a little bit about future directions. So, what are the etiologies of the various etiologies of olfactory impairments or disorders? I mean, aging alone is the greatest predictor of whether you're going to have problems with olfaction or not. As we age, our olfactory capabilities go down. It's been strongly associated with almost every neurodegenerative disorder, Alzheimer's disease, Parkinson's disease, Lewy body dementia. And then after that, the next most likely cause of olfactory problems are viral illnesses. So HIV, COVID, other viral illnesses that people get definitely have an impact on people's olfaction. And then other problems with the sinuses, and then TBI exposures, et cetera. So, and then I think this is really important in the context of Allison's talk, where she's talking about we have good ways of correcting for visual loss. We have good ways for correcting for hearing loss. We don't have good interventions for olfactory loss. And if I'm wrong about that, please let me know and speak up in the Q&A. So, but I think that is one of the things that creates a real challenge here with olfaction as compared to other sensory impairments. So when we talk about talk about olfaction, there's different ways that we can assess that. So you can do odor identification. So can you identify the presented odor? You can do discrimination. Can you tell the difference between two odors? And then odor threshold, which is basically how much of the smell do you need before you can sense it. And there's different assessments that hit these different areas. Most of the literature uses what's called an odor identification test. And the most common one, especially in the context of HIV, is the UPSIT, or the University of Pennsylvania Smell Identification Test. And this is 40 items. It's literally just a scratch and sniff sticker. And yes, I was a fan of scratch and sniff stickers when I was a kid. Had a little collection. They do lose their scent after a while. So you scratch it off, you present it to the participant, and then they have 4 choices, and they choose one of 4 choices to identify the smell. There's also a brief version that has good correlation with the longer version as well. There's other assessments too, sniff and sticks. I have no affiliation with any of these products. They're just what's often used in the literature. And then, so what's the prevalence of olfactory problems, impairment that we see in aging just in general? This is pre-COVID, and I think we need to just think about how COVID may have impacted this moving forward. Estimated to be about 12 to 25% of the US population had olfactory impairments. And when you self-report and you ask people if they're having problems with their smell, it's much lower. And olfactory impairment does increase with age. So how has it been tied to dementia? And again, I'm using Alzheimer's disease as a model so we can think about how it may apply to people with HIV. Olfactory impairment happens relatively early in the clinical indicators that you can identify in Alzheimer's disease. And Alzheimer's disease typically starts, although the data are starting to show that it's pretty varied, starts in the entorhinal cortex, which is associated with olfactory functioning. And multiple studies have shown that you can see olfactory deficits in AMCI, earlier stages of Alzheimer's disease, and in people who have no presentation of cognitive problems yet, but are at risk for Alzheimer's disease, such as those with a family history of dementia or who are ApoE4 positive. And you can see that here, everybody loves a good picture of the brain, or at least I do, or schematic. So you can see here, let's see if I can do it on the screen here. You can see the entorhinal cortex here. There we go, the large green part there. And then you can see the projections coming forward, the olfactory bulb, the olfactory tract. Those are impaired in Alzheimer's disease and involved in olfactory processing. So, we just talked about vision. When you look at a study predicting the onset of cognitive impairment, and you use different sensorium evaluations, all of these are actually significant predictors of the onset of cognitive problems. But the strongest of the predictors is olfaction. And so I think it's important for us to think about that as an early assessment. And again, we don't have a good intervention for that. So thinking about as a way to use olfaction as an assessment to find cognitive impairment or to identify it before it happens. So, and then COVID really brought olfaction back to the spotlight, and people started wondering about both taste and smell. And people may or may not be aware, there's a huge study called the RECOVER study, which is evaluating thousands of people who had COVID. 3,500 participants here, middle-aged, interestingly, mostly female. And in those people, the people who self-reported changes in olfaction, about 80% of those people had actually identifiable olfaction impairment on the OPSIT, the smell identification test, and about 23% of those either had severe or no remaining sense of smell. And then if you take the people who didn't report any problems with smell, they also actually, 66% of them had some problems with smell, and 8.2% had some significant impairments. And this is a table from that study. If I can orient you to the bottom red part, the abnormal OPSIT row, you can see that there's roughly 67% of people who had self-reported problems with their thinking, and then as compared to 63.5% of the people who had no problems on the OPSIT. So not a huge effect. This is a really large sample, but there are differences there. The second column, or the third column here, shows a more objective test. These are probably not clinically meaningful differences, but were significant differences. Again, the people with abnormal smell did worse as compared to those who had normal smell. So again, there's some relationship between smell and cognition in the context of COVID. So olfaction and HIV, this has been something that's been identified for a long time. It's a paper from 1995 talking about taste and smell among people with HIV. And there's been some nice reviews. David Vance did some really early reviews on this topic, talking about what is happening in people with HIV and smell. And there's lots of different causes that we can think about. Oral and sinus complications that can occur in HIV. We know that there's a higher prevalence of smoking among people with HIV, which can certainly impair people's olfactory functioning. Medication use, I think the jury's still out, but there's some indication that antiretroviral therapies may, it's a little bit of a chicken and egg question, but may be associated with that. And then we can see some problems in terms of brain function as well. And then those similar areas are found in people who are aging. So once you put those two together, you can certainly see the opportunity for decline. And I should go back and just say that there's been proposed interventions, but such as odor augmentation, but none of those have been shown to be really fruitful. David Vance did a objective study using the UPSIT test that I've described. This is a middle-aged sample of about 50 people, and showed that the UPSIT was related to a verbal learning and memory test. And that's consistent with some of the data from our group too. Aaron Sunderman, who's here with us and probably should be giving this talk, did some work, and this comes out of the NNTC, the National Neuro-HIV Tissue Consortium. We took people who were over age 60, and we, on the x-axis, you have the UPSIT score, maximum score of 40, and then on the y-axis, the left column represents the Hopkins Verbal Learning Test revised, with the top panel A doing the recall scores and panel C being the recognition scores. Panel B is the brief visual memory test revised, and that has the recall scores and the recognition scores. And you can see that as you're the people who have poor performance on all these measures, both the Hopkins and BVMT, have worse UPSIT scores as well. Not a huge effect. There's a fair number of people, pulling things down in the lower left quadrant, but definitely there is a significant association that we found there. So, we've been working really diligently to try and understand and pull out people who may be on a traditional neurodegenerative trajectory from those who may have HIV-associated neurocognitive disorders or some neurocognitive impairment, however you might want to categorize it, and to really identify those people who might actually be at risk or have Alzheimer's disease or burgeoning Alzheimer's disease. So we're trying to pull this little red part out from the hand group, and how can we do that has been something that we've been working on. And we've been leveraging a diagnostic tool that's been used within the Alzheimer's and AMCI literature. So really taking people who have recognition impairments, and that's really rare in most people with HIV. So, but if you find those, it may be indicative that people are actually on a more type of neurodegenerative or Alzheimer's disease trajectory. So we've used that in this next part of this study with the smell test. So the people in the green bars here are the exact same people as in the purple bars, and we just either diagnose them using hand criteria in the purple, or we diagnose them with the AMCI criteria in the green. And what you can see is that the people who are diagnosed as high risk for AMCI, which is the leftmost bar here, they have significantly lower scores than those people who are not at risk for AMCI. And it's not just this is differences within the normal range. These are at the range of moderate levels of olfaction impairment. But if you just use hand criteria, and say, do people have hand versus no hand, it doesn't discriminate between the OOPSIT scores do not differ between those two groups. So this suggests that there are these people who may be on more of a neurodegenerative trajectory, early looking at risk for Alzheimer's disease, and the OOPSIT or smell identification may be something that we can use to tease those people out. So there's some other studies that I didn't have time to review, looking at the Iowa gambling task that's associated with olfaction. There's definitely room for growth in terms of assessments here. There was a novel test that looked at actually taking things like peanut butter and putting it in front of people, and that didn't correlate with the OOPSIT, so it makes you wonder what is the exact parallel here. And then there's definitely challenges in terms of people's self-report of their olfactory problems and the objective assessment, and things like the smell tests are expensive. It's $20 for each one of them. So it is expensive to assess, but really seems like it can get us something beyond self-report. So this is a figure taken from Claire Murphy, who's a collaborator at SCSU and has shared some of these slides with me. She's really an olfaction expert. I'm just playing one today. But the interesting thing in the context of Alzheimer's disease is you get amyloid beta early in the process, which is the blue line. The green curve, light green curve, is the tau, which comes on later. And then you have some brain structure changes that appear after that. Finally, some recall or memory changes, and then clinical implications. Olfactory functioning happens somewhere maybe before you can even see brain or structural changes in Alzheimer's disease. Again, suggesting that it might be something that we can look at early. So in terms of future directions, I mislabeled the consortium that I'm working with as National Neuro-HIV Tissue Consortium. We are the California Neuro-HIV Tissue Network, so I merged the two in making this slide. But the NNTC has a cohort of people that's we follow in life. It's about 500 people. That's across Mount Sinai, which Jessica is affiliated with and is going to speak next, Washington University, and UC San Diego. So those are in-life folks that we're following. We do really comprehensive and detailed assessments. We're trying to figure out actually how to streamline and trim those, but it's really a full day of assessing. We get neuropsychological data, psychiatric substance use data, medical data, neuroimaging now. We do blood and CSF draws. And then we've recently, over the last year, added the brief smell identification test to that cohort. Probably have over 150 assessments there, and we're getting data on that longitudinally too. And ultimately, these individuals have agreed to undergo autopsy at the end of life, and we can look at actually neuropathology in a subgroup of people there too. So that'll be a very interesting way of looking at smell longitudinally that we haven't been able to do before with potentially pathologic outcomes. And then just in summary, I think there's good evidence that olfaction is disrupted in people with HIV and it worsens with age. That those impairments may be more strongly tied to neurodegenerative diseases and not just associated with hand or other cognitive problems that we may see in people with HIV, and might be an early indicator of that neurodegeneration. And I think that's really important. I think we want to reassure people with HIV about over 50% don't have any cognitive problems. We have another group of people that have some mild problems, and most of our data suggests that that's a stable mild impairment in most cases. But then we have some people who decline, and is that just a subset of people who would have declined regardless of their HIV status? So I think that's what we're trying to identify. And assessment of smell is easy, although there is a cost. and it may be helpful in the case of suspected neurodegenerative diseases. And as always, it takes a team. This is definitely not all the members of the team. Thank the study participants, our community partners who really help me remember, why are we doing this? Michael always says, so what? What does it mean? And I always appreciate that and try and keep that at the forefront of our research. Some key doctoral students, staff who helped me put this together. Claire Murphy, who shared slides with me, Aaron Sunderman, who helped do some of the seminal work, and Scott and Ron, who've been longtime amazing collaborators. Thank our support from the NNTC and the CNTN, and we had a study from NIA also looking at Alzheimer's disease in hand. So thank you very much for your attention. Happy to take questions later. Thanks.